where either from a little bit of bone loss or over eruption, but you'll find patients that you'll sound a bone and this dimension is just bigger. It might be 5 millimeters. Now, sometimes the tissues are piled up and you sigh and you feel the CEJ and then you run into the bone about here. But these patients, because there's a longer than normal distance and the bone is often in a pretty normal place, they often lend themselves to being able to gingivitis. Okay, so I want you to sort of be thinking about the different options here. This is about 60% of what we see. The high crest is is not that common, but it's out there, and the low crest is about 30%. So if you're messing with bone levels, it means probably about 70% of the time, if you're doing it, you've got to take a little bit of bone. It's more grounded thing. About 30% of the time, we're probably doing gingivitis if we want to have long-term stability. So let's look at, now this, I talked a little bit about that, I want to be clear about it. So remember, active eruption is the process where the teeth are erupting out of the bone, and passive eruption is when the tissues are receding into the position that they should be, right? So in this particular patient, we've sounded down the bone, and as we put the probe in and ran along and felt the CEJ, then we went a little further and we ran at the bone, and this is about a 3 millimeter dimension. So tissues are sitting about in this area. Dimensions about 3 millimeters, and notice about 1 millimeter, 1.5 to the CEJ. This patient erupted normally and also had normal past eruption where the tissues receded. Now we compare that to this one where the teeth are square, and we go ahead and look at it, and for whatever reason we sound to the bone on this one, we feel the CEJ and then run into bone, and it's about 5.5 to 6 millimeters to this osseous crest. But look, the teeth erupted pretty normally. This is normal active eruption, but for whatever reason, this thick pariotype is just piled on top, the late pass eruption. This one is perfect for gingivitis, right? So you could do laser, you could do electrosurge, you could do blade. The tissues don't really care. I will say the zone of the necrosis on the laser is like 50 microns, and the electrosurge is about 500 microns, so there is that. So I do like using laser for this type of work. And then the last one, kind of irregular tissues, and this is what we see a fair amount where you have the thicker pariotypes, but we sound down the bone, and as we're running along, we don't feel the CEJ at all. That's because we run into the bone first. This is a person who did not have normal eruption. So this person has delayed active eruption, the teeth didn't erupt normally, and the tissues are piled on top, and it's delayed pass eruption. So this is the one where the periodonts is going to reflect and move the bone out where it should be. Now, I used to really, before I understood this, I would get a little freaked out when the surgeon would take bone away. It's like, should we be taking the bone away? Like, that seems like we're trying to preserve the bone. But in reality, when we diagnose it right, we're actually putting the bone where it should be if the teeth are up. Okay, so that really helped me feel better a little bit about that. So again, we start thinking about margin placement. When I'm doing crowns, I like to know kind of what sort of tissue that I'm dealing with. And so sounding the bone is something I do on every restoration, because if I drop my probe in and they have a normal probe depth, but I sound the bone and it's like 5 millimeters, those are the patients that often the tissues recede. And everybody, if we're honest, we've done a crown where you know you were at the tissue or slightly subgingival, patient comes back and you're putting in the crown and now a millimeter, the margin's a millimeter above the gum. And it's usually because we had that sort of low crest type situation. If you run into that, your choice is go a little further into the sulcus, right? Drop your margin a little bit, or you can pick up a laser, electrosurgery, just do a little gingivectomy, make it 3 millimeters, and it'll be stable there. When we start thinking about the gingival architecture, so we start thinking about from our margin to the bone is 3 millimeters here. And if you've read Tarnow's work, you know that interproximally, if our contact point is 5 millimeters from bone or less, we're never going to have an open flat triangle. All right, so 3 and 5 are the numbers that we're working on. So a situation like this, where I've got a 5 millimeter, I can feel the CJ at 4 millimeters, and I'm prepping, it's not common for me to go ahead and create a 3 millimeter dimension, create the balance. This is old. This is when I was using electrosurge. Today it would be laser, late. Again, it doesn't really matter. Biology is biology, and they will heal the same. All right, so let's look at osteosurgery. We're going to look at my daughter here. I started thinking about her case. She's a dentist who practices with me now. This is a very early picture of her. I think she's about 13 or 14 when we took this. But she just, teeth erupted in her mouth. They were short. They were shorter teeth. They were definitely probably 110%